Good evening. Thank you everybody for coming out and actually finding the room. I think that was probably the first and biggest challenge of the evening. So it's really nice to see everyone. So we have an excellent group of speakers tonight that are going to talk to you about some of the innovations and exciting discoveries in neuromuscular disease and ALS in Ottawa. I'll just wait for our slide deck to get loaded. There we go. So just as far as format and housekeeping, we're going to have our 4 speakers that will come up and talk, and then we'll take our question and answer period at the end. If there's any burning questions, because we're an intimate group, we can probably interject, but there'll be lots of times for questions at the end. So the 4 speakers tonight. I'm going to speak to you about some of the clinical research discoveries and some of the changes in clinical care in neuromuscular disease. Dr. Robin Parks is a senior scientist at the Ottawa Hospital Research Institute, and he'll be talking about some of the translational research in both diagnosis and therapies. Dr. Ari Breiner will be speaking to you about the clinical trials in ALS, and that will be used as a model for other neuromuscular disease trials in Ottawa. And Dr. Michael Rudnicki will be talking to you about exciting stem cell therapies in Duchenne muscular disease. So as far as neurological disease, some people say, well, what exactly are neuromuscular diseases? So if you look at neurological diseases as a whole, you have there we go, brain, spinal cord, and then down to the nerve and muscle. So those are neurological diseases as a whole. Neuromuscular diseases are between the spinal cord, the nerves, and the muscles. And so specifically, disease of the spinal cord, down the nerve for neuropathies, neuromuscular junction, and then muscle disorders. So some of the common muscle disorders would be the muscular dystrophies, and there are hundreds of different subtypes, or autoimmune muscle diseases. The myasthenic syndromes, so between the muscle and the nerve where they interject for myasthenic syndromes and congenital myasthenia. The neuropathies, both the autoimmune acquired, so Guillain-Barré syndrome and chronic inflammatory demyelinating neuropathies, and of course Charcot-Marie-Tooth, which is one of the most common neuromuscular diseases. That's a genetic autoimmune disorder. And then the motor neuron diseases, which are neuropathies but start in the spinal cord, and of course ALS and spinal muscular atrophy are the most common examples. Now, many neuromuscular diseases are multi-system disorders, so they don't just affect the neuromuscular, sometimes they'll affect the eyes, the heart, the brain, and so mitochondrial diseases and myotonic dystrophy are common, but there are 100 diseases. So neuromuscular disease by the number. Our new clinical research center is expected to help 10,000 patients in Ottawa with some very mild diseases and some very severe diseases. There are over 200 subtypes of neuromuscular disease, and over 60 people in Ottawa that are clinicians and scientists working in neuromuscular disease research. So why haven't we found a cure? So whenever there are billions of dollars poured into research, what are some of the barriers of finding better treatments and better ways to diagnose these diseases? For the genetic diseases, there are thousands of different subtypes that are known and thousands that remain to be discovered. And for many of the autoimmune disorders, we are discovering new autoimmune diseases every week. There we go. So our animal models are critical in discovering basic science discoveries and model and mechanisms. However, they don't always represent the human condition. And finally, we need more clinicians and scientists working together, because when we work in our silos, we will not lead to a cure. So what we have to look at is moving forward step by step, how that's going to make a change. And one of my favorite stories is, so many of you may or may not be on a medication called a statin. And so Lipitor, Crestor, you probably see the commercials on TV as well as all of the reasons why not to take it. But the medications called statin were first found from a family with hypercholesterolemia, or very high cholesterol. So even though this family with this very, very rare disease this medication was found, this has helped millions of people across the world. And so although sometimes when we hear saying pushback, saying why would we support medications for patients with such rare disease, but this will help patients with all different types of diseases. And we're really looking for the era of personalized medicine. So the medicines that will help each patient, but can also be generalized to the population. And looking at our neuromuscular strengths. So in Ottawa, we need to find the place, the people, and the process to change research and clinical care. So the place. So we were very fortunate to, over the past 2 years, we needed a center that's going to assemble the neuromuscular neurologists, the technologists, and the research coordinators to help us deliver better care and develop more therapies. And so after about 2 years of planning, the clinic finally opened. And so originally there was going to be a $4 million budget. And you think, well, a $4 million budget, that's a bit decadent where we're going to be building a hospital a new hospital in the next 10 years. But 10 years is a long time to wait to develop new therapies, and we need this clinic now. So with restructuring, we were able to do it for a very modest price of $800,000. I'm not sure if any of you have had your houses renovated recently, but that seems like a pretty good deal to develop a $5,000 clinical research center of excellence. And so the storm before the calm, this was quite a huge undertaking, and we certainly are appreciative to all the patients that were displaced and moved around and had their clinic appointments moved. But the Neuromuscular Center opened in May, and we had excellent fanfare. There was a lot of support in the community. And so we had a lot of news coverage just because neuromuscular diseases do affect the 10,000 patients in Ottawa. And so I would particularly think if you ever want something in the news, make sure you say the word game changer, because that seemed to be picked up by every single news outlet that was there. And so we're very lucky to have live coverage talk about the Clinical Research Center. But I think importantly, and most importantly, we were able to talk about the stories and the patient advocates. And the Clinical Research Center was really open because of the strength and the need and the demand of the community. And we certainly appreciate your support and your hard work to make this happen. And this story is supporting Ms. Teresa Buffoni, who's here tonight, who's got a wonderful story that she tells about her family with myotonic dystrophy, and she's been an incredible advocate for patients. And I call her a super advocate, and we certainly appreciate all the hard work that she has done. So moving forward, we have this new clinical research center. So what are we going to do to make things happen to change the rate of diagnosis and the potential therapies in Ottawa? So first of all, we need we talked about the place, now we need the people. So we have assembled neuromuscular disease clinical expertise so that we can have all of the innovative clinicians, technologists, research coordinators in Ottawa together. We also, he's not in this picture, but we also, Dr. Hans Lochmuller, who's one of the biggest clinician scientists in the world, has recently started in Ottawa, like 3 weeks ago recently. But one of the reasons was that we're able to have a clinical research center that can support his level of research. And that bodes well for attracting even more international talent in the future. And so in the next 6 months, what we want to do with this clinical research center is really be able to deliver cutting-edge clinical care. So be able to, from a diagnostic perspective for the blood markers, the serum markers, to be able to do the electrodiagnostic techniques that are very challenging to do in a clinical research center, as well as doing things like muscle ultrasound. Many people have not had that as part of their diagnosis, but that can both provide a faster diagnosis and also be able to help us tell if our new therapies are working. And for anybody here that's had a muscle biopsy, it is not an easy process. We don't want to oversell how hard it is, but we're looking for ways of doing muscle biopsies in a less invasive way for patients with neuromuscular disease, and skin biopsies and other samples. Another thing that we can do too is have better ways to diagnose at the hospital. So with the clinical information, we can have them in the clinic. If you looked, so here's an MRI of your lower leg. So if you think of where your calf is, and this is the bone at the front, the tibia, you don't have to be a radiologist to see that the white part in the calf is a muscle that's been affected by a muscular dystrophy. And if we can use these patterns, we can actually help not only help with the diagnosis, but as well as a response to therapy. And you can see that all of these different types of muscular dystrophies, and this also applies to nerve disorders and ALS, that the new imaging techniques will help us better assess and importantly, better assess response to therapies. We will also have the ability to deliver clinical trials. So you probably, if anybody has read the paper, you've seen the story. So when I was a fellow for about 2.5 years, every week I'd go to Montreal, and I would see families that would be, in their wheelchairs, loading up on the train with me to Montreal, getting clinical trials that we weren't able to deliver here. And I thought, if I was so fortunate to come back and work in Ottawa, that we would be able to deliver these clinical trials right at home. And so as part of this new clinical research center, and Dr. Breiner will be talking about that afterwards, we will now be able to have both clinician investigator trials, so trials that we were able to discover right here at home, as well as the large multinational trials. So this isn't just regular care, but it's really the cutting edge care of tomorrow. As well as doing things like natural history studies. And natural histories are following patients. They're not nearly as exciting as the cutting edge clinical trials, but they are essential to show that therapies work. So we have to be able to change the disease course, and that is really important for regulators like Health Canada and the FDA. So this is essential to show that our new therapies are working. And so when we implement clinical trials in Ottawa, where we're starting off is our collaborations with our basic scientists, that when we're able to have tissue as far as blood or skin biopsies or muscle biopsies, this is going to help our basic scientists, who are really among the best in the world, develop new ways of diagnosing and delivering better therapies for patients with neuromuscular disease and ALS. And as well as developing the clinical trials. So many of the clinical trials are here, so those are big pharma companies. But we also want to cultivate the earlier trials because we have such cutting edge responses to therapies here. And developing the infrastructure for one disease like ALS or spinal muscular atrophy or some of the more common muscular dystrophy helps all patients with neuromuscular disease, because when we have the infrastructure delivered for one disease, we can apply it to many different diseases. And so if we have a patient registry, so if you've got one patient with one small disease, a big pharmaceutical company might not want to come invest in Ottawa. But now that all the neuromuscular neurologists are together in one group, we can say, well, we actually have 10 patients. And that might not sound a lot, but we might have more patients. And in some groups, we have more patients than any other group in Canada because we're working so collaboratively together. So this is really important to bring funding, money for clinical trials, and support the research and clinical care for our patients. We also are developing a tissue biorepository that Dr. Parks will talk to you about. So that's the blood samples and muscle samples. We need a spot to put it, right? We can take it in the clinic, but you need a spot to store it safely so that our patients can use it and our scientists can use it later on. We talked about the muscle and nerve imaging that will help us diagnose and deliver better therapy. And that's sort of that is like a time for a talk, but that's okay, as well as the clinical trials. And so again, the infrastructure that will help with one trial will help with all trials. Just think of what my next slide is. It'll come back on in just a second. So there, perfect, okay. Clinical trials, there we go. And again, the infrastructure that helps with one rare disease will help for all. So you're thinking, well, this is great, but when I go for my clinic visit, how is this going to change my clinical, I went to this, how does this change from a clinic visit to really a center of excellence? And so basically when you come and see your neurologist with a little reflex hammer, we now are in talks with a cardiologist. So it'll be the first time we'll have a neuromuscular cardiologist in Ottawa. So that's for helping, and that's excellent because there's so many neuromuscular disease where there's cardiac involvement. And this will also help us with our natural history studies, which I mentioned are important. Often we have to give, when we're doing a diagnosis, to give blood, one little extra vial of blood or an extra little bit of tissue is a game changer. See, the game changer is an important word. The game changer for the scientists in the Research Institute, because they will be able to, they will be able to work on tissue samples where they can actually test whether medications can work. So this will help us move their clinical trials of their excellent work that they're doing into the clinic. And last but not least, obviously we want to give you the medications that are standards of care and best practice, but now we can also deliver the medications that are cutting edge, that are the medications of the future. And so this is over the next 6 months to 2 years for every patient that comes in with a rare disease in the clinic. We want to be able to offer all of this. So although we don't feel older, we're all getting older. So it's really important to invest in both the physicians and the scientists of the future. So we worked really hard to develop training scholarship programs, fellowship programs for the medical students, the residents, and the graduate students as far as developing an expertise in neuromuscular disease. And finally, we're here for you. We're always honored that you're coming here to see us, but really we're doing this as part of you. I'm, honored every day in clinic when I see what patients are living with, and it was with such grace and honor. And so we're looking for stakeholders for the Neuromuscular Center. We will be developing a board over the next 6 months to a year, but it's really important because we always want to support our own disease, but we have to look at this as a cohesive and how we can help all patients with neuromuscular disease and ALS in Ottawa. And finally, we talked about some of the local efforts, but importantly, we need to reach out to our national partners and our international partners because what is being done here can be shared elsewhere and vice versa. So we, in Ottawa, we are supporting the Care for Rare, which is an excellent initiative through CHEO for finding of rare disease genes, as well as our colleagues across Canada, the large Calgary group that's, so if people aren't familiar with it, that's the Canadian Neuromuscular Disease Registry. I encourage you all to sign up and register because that is trying to collectively look at the incidence for patients with rare neuromuscular disease in Canada. As well as we have international partners in Miami, Lyon, and Newcastle, and Dr. Parks will be talking a little bit about that in the future. So it does take a village to build a clinic. Or a clinical research center. This isn't just a clinic, but we're really trying to provide the best in clinical care as well as research. And I'd like to thank, in particular, the hospital administration at the Ottawa Hospital, as well as at the university, because really they have been instrumental. And we would not have been able to have the funding, the space to make this happen. I particularly want to thank our patient supporters. So we have 3 people. So Ms. Anne-Marie Gianetti, who's a strong advocate for patients with ALS, and her beloved husband, Luigi. Ms. Karen Lawrence, who has a very personal and compelling story for patients with ALS. And then Ms. Buffoni, who I mentioned beforehand, for myotonic dystrophy. But there are hundreds of patients that we have heard from, have listened to, and this clinical research center will evolve because of you and your feedback. So we appreciate all of your support. And so people are, when we first heard, they're like, aren't you so excited? Like, the clinical research center is open, are you happy? I'm like, this is just step 1. So we really have to move this clinical research and so now we can provide more comprehensive care. And now we can offer clinical trials. But really the next step is looking at the translational research. So I would like to invite Dr. Robin Parks. He is a senior scientist at the Ottawa Hospital Research Institute and my co-director of Centre Neuromuscular Disease. He did his PhD at Guelph and his postdoctoral studies at in Hamilton. And he's been an excellent colleague and partner in neuromuscular disease. And really what I think is unique about Ottawa is that we have the basic scientists and the clinician scientists working together, and that's very unique with the amount of patients, clinicians and scientists we have. So I will pass the mic over to Dr. Parks. Thank you very much for your time.
That'd be me. So it is a pleasure to be here and to be able to talk about some of the work that we're doing here in Ottawa. I'm largely going to follow on with what Dr. Warman was talking about and talk about some of the efforts we have to try and bring the basic research and the clinical researchers together to come up with the new approaches and the new treatments and cures for some of these disorders. And I'm going to talk about translational research. That really is trying to take some of the findings we have at the bench, in the laboratories, and also in the clinical trials, and trying to move them forward into to patient care. So as Dr. Warman mentioned, we have about 60 specialists in neuromuscular research, both scientists and physicians. With regards to the scientists and physicians, they are located at the Ottawa Hospital, at the University of Ottawa, and also at CHEO. And we have a number of people that work in a number of different, on a number of different disorders. So some are just working on trying to look at normal muscle development, motor neuron development. Others are working working on specific disease types like Duchenne Muscular Dystrophy, Spinal Muscular Atrophy, or Myotonic Dystrophy. With regards to our physician colleagues, we have them that work in a variety of disciplines. We have a number of neurologists and neuromuscular neurologists. We have diagnostic imaging. So we really do have a wide breadth of expertise here in Ottawa that really isn't found in other places. And we should be really proud of this because we probably have one of the largest groups of neuromuscular researchers in the world, and that's here in Ottawa. So it's something to be proud of. And not only do we have a large number of researchers, but we also have world leaders in a variety of different areas in neuromuscular research. So the first picture there was Dr. Michael Rudnicki, who's going to talk later today about some of his work. And Dr. Rudnicki is a world leader in studying stem cells and satellite cells and how they give rise to more normal muscle development, and also more recently working on developing therapies to treat some of these disorders. On the other side of the slide, we have Kim Boycott, who is a researcher who is at CHIO, and she's one of the world leaders in identifying new genes for rare disorders like neuromuscular disorders. And so we really do have people that are world leaders, many world leaders in the field, and we should be quite proud about that. And one of the reasons we should be proud and thankful is that really to make impactful research in any field, you have to have collaborative research teams. The days of just sitting in a microscope and looking down your microscope and doing your research are over. You really have to have experts working with you that are experts in a number of different disciplines. So I'm a basic science researcher, and I'm very good at, in my lab, working with tissue culture models and cells and animals to try and uncover some of the mechanisms of disease and looking at potentially creating new therapies. But really, I can only take my research so far. I'm a basic researcher. I don't have encounters with patients. I'm not licensed to do that. So my research is really confined to working with animal models. In contrast, my clinical research counterparts work very closely with the patients to understand at the patient level what's happening with these disorders and to try to understand the patient experience and really come up with new ways to diagnose these diseases more quickly, more rapidly, and more effectively, and also do clinical trials. To give relevance to my research, it's really through these interactions with these clinician scientists that can do that, where we can get small blood samples or cells or pieces of tissues that we can start to ask some of the questions that we've sort of raised in our tissue culture and our animal models and see if they're relevant to the human condition. So if I can show that what I see in animals is actually true in the human condition, it really increases the impact of my research. I can also test new therapeutics, not only in these animals, but move them forward in testing into cells from patients that have these disorders, and it gives it much more relevance to what we're doing. So in return, what hopefully we can do is take some of these new therapeutics we've developed in the lab and move them forward to treatment in patients. And it's really these types of collaborations between the basic researchers and the clinician scientists that are going to move the field forward. As Dr. Warman mentioned, one of the things we want to do in the new clinic is hopefully every patient that comes into that clinic is consented for research. Now really there's two types of research. There's the ones that we're really excited about, where there's new therapies coming down the pipeline that we're trying out in patients, and hopefully they'll have a beneficial effect in clinical trials. But for those patients where there are not clinical trials, you can still be consented for research. And in that case, we may just ask for a simple blood sample or a sample of cells that we'll essentially put in the bank. And literally, it's a biobank. It's a big freezer where we will store these samples. So down the road, one of our researchers requires, let's say, a dozen blood samples from patients with spinal muscular atrophy. Instead of having all those patients come in so we can get the blood samples to deliver to those basic researchers, they'll already be in the bank. You can basically just go to the bank, make a withdrawal, get your 12 blood samples, and hopefully move your research forward that way. It's a much more efficient way of doing it. And not only do we want to share these, of course, within the local community, but these would be available to other researchers nationally and internationally, what we would hope. And that's kind of one of the things that we're trying to do, is break down the barriers of these research, bring the clinicians and scientists together, and also the people at the various research institutes here in Ottawa together to work on these neuromuscular disorders, so that there'll be a free flow of reagents or cells or ideas between the University of Ottawa, CHIO Research Institute, and the Ottawa Hospital, and that's what we're trying to achieve with this new clinic. So one just small little example I'm going to give, it's a study that we did that was published about a year ago now, and I'm not going to go into too much detail, but essentially it involves some work we were doing on spinal muscular atrophy. So for those that don't know, spinal muscular atrophy is due to low levels of the SMN protein. And what we did is we essentially developed just a simple blood test where you could monitor the levels of this SMN protein in blood samples. Now, there's very good diagnostics out there already for spinal muscular atrophy, so developing a blood sample, a blood test, is not really that innovative. But what we're particularly excited about is perhaps using this assay that we developed where we can start to test some of the new therapeutics and see how they're working. So there's a new therapeutic that's becoming available, it's called Spinraza, that can be used to treat patients with spinal muscular atrophy. And the questions we want to ask is basically if you take a blood sample from these patients that are being treated with the Spinraza before and after they're treated with this drug, can we actually monitor what's happening with this treatment? And what that means is that we can perhaps develop personalized medicine where you can treat them more frequently or with a higher dose if it's necessary. It's just by simply doing a simple blood test, and that's what we're quite excited about. And this research was actually supported through a grant that we got from Cure SMA. So it's a charitable agency that specializes in patients with SMA, and there's a Canadian branch and a US branch. And although I was the lead on this particular grant, I couldn't have got it without my clinical counterparts. And so the co-applicants on this were Dr. Rashmi Katari, who's a senior scientist at the Ottawa Hospital, but also Dr. Warman, who's an adult neuromuscular neurologist at the Ottawa Hospital, and Hugh McMillan, who's a pediatric neuromuscular neurologist at CHEO Research Institute. So we all got together and we were able to get a grant to support this work that we're doing. And that's really the type of thing that we're trying to achieve here in Ottawa. So one of the other things we're trying to do in Ottawa is really brag about what we have. And so we're trying to put Ottawa on the map, sort of neuromuscularly speaking. And so a number of years ago, we decided to hold a big international conference. So what we did is we invited 40 or so world leaders in various aspects of neuromuscular disease and clinical care, and to bring them to Ottawa. And we held a rather large conference. The idea is that you open up, you invite people, specifically big people who are well known in the field, and you open it up to other scientists to come out and attend and see these people speak. And so we had about 300 people that came here to Ottawa from nationally and internationally to attend this conference. And the idea is to really just to exchange ideas and get people talking about how they can move the research forward. So we had so much fun with that first conference, we held it 2 years later in 2017. And what was interesting after that conference is we had people coming up to us and saying, well, you're going to hold this again, right? Because it's now became a marquee event where people were recognizing that Ottawa is the place to come to start to talk about these neuromuscular diseases and potentially coming up with new therapeutics. So of course we are doing it again. So in the fall of 2019, we're going to have another meeting where again, we're inviting about 30 people or 30 or 40 people who are world-renowned experts in their research fields in neuromuscular research, and open it up to other trainees and people to attend and hear these people speak and just talk science. We're also trying to take our Ottawa approach and expand it around the globe, and so we've established research partnerships with other institutes, and one of the main ones we have is a research partnership with the University of Lyon. Lyon in France has a very large neuromuscular research group too, and so we signed a 5-year agreement for $1 million to fund neuromuscular research, specifically neuromuscular research. The idea being is that you can apply for a joint grant between a researcher here and a researcher in Lyon to try and move the research forward. You can have graduate students that spend half their time here and half their time in France, which is a pretty good deal. And hopefully work on collaborative programs that really move the research forward and come up with new approaches. So we were quite excited about that. And of course, we also here in Ottawa have a commitment to our patients, both with education, where we come out to nights like this to talk about what we do here in Ottawa and answer some questions that you may have. And we've gone out to do the kickoff for the ALS walk, and we've gone to patient support groups, and we were glad to do that. And in the final panel there, the Max's Big Ride, well, Max is a young boy who's got Duchenne Muscular Dystrophy, and his father, Andrew, bikes from Hamilton to Ottawa every year, and he takes Max on the bike, and it's to raise money and awareness for Duchenne Muscular Dystrophy. We were happy to host them for a day event that we had at the Faculty of Medicine at the University of Ottawa, and Max got a little lab coat, so it was actually kind of cute. We're also committed to fundraising. We've gone out for well over a dozen years to the Walk for Muscular Dystrophy, which is a great event, and we're quite happy to say that we've probably raised about $40,000 or so over the years that goes to local families affected with neuromuscular disorders through Muscular Dystrophy Canada. We've also done the Ice Bucket Challenge a number of times and had cold water dumped over my head. That was kind of fun too, actually. It's nice when it's done on a warm summer day. And I think that our efforts are being recognized to a certain degree. We were fortunate back in 2016, so just over a year ago, that we received the Researcher of the Year Award for Muscular Dystrophy Canada, sort of in recognition to some of the outreach we do, but also the fact that we've got a solid group of neuromuscular researchers and clinicians that are really dedicated to moving forward what we do. And so it was kind of nice to get that, and it makes us feel like maybe we're moving things in the right direction, and we're quite proud of that. So just in closing, I hope I've been able to show you that we're working hard in Ottawa to move things forward, to bring the basic researchers and the clinician researchers together to come up with common goals and approaches and new treatments for these various disorders. We're trying to move things around the globe. We're trying to link up with other countries and other provinces to try and expand our efforts. And really, in essence, what we're trying to do is take today's research and turn it into tomorrow's therapies. So thank you very much. So it's my pleasure to pass things off to Dr. Ari Breiner. So Dr. Breiner, he did his medical studies at McGill University, followed by residency at McGill and University of Toronto. He then started his faculty position at University of Toronto in 2014, but we were lucky enough to steal him back here in 2017, where he started at University of Ottawa and the Ottawa Hospital. So he's a neurologist who is taking the lead really on ALS care here in Ottawa, amongst other things that he's dedicated to. Thank you.
All right. Thanks very much. Thanks for the opportunity to speak. I'm going to shift gears a little bit and wait for my slides to be loaded. We're good? So we'll shift gears a little bit, and I'd like to provide a little bit of an update on the new and hot topics in ALS care, and specifically in clinical research and new therapies in ALS. These are some disclosures. So a bit of background to begin with. ALS is also called Lou Gehrig's disease, and it's a neurodegenerative condition that really burst into the public's consciousness in the late 1930s when Lou Gehrig was diagnosed. He was a professional baseball player for the New York Yankees. And when the diagnosis became public knowledge, Gehrig actually gave a press conference in front of all the fans at Yankee Stadium, and he started his address by saying, "For the past 2 weeks, you've been reading about a bad break," and he was referring to his diagnosis. He said, "Yet today I consider myself the luckiest man on the face of the earth," and those are famous words. And I think it's that energy, that resilience, that positive attitude in patients with ALS that really inspires many of us that work with patients with ALS to continue what we do. What is ALS? Well, ALS is a progressive neurodegenerative disorder that paralyzes motor neurons in the brain, the brainstem, the spinal cord, and in the arms and legs. People who are affected can present with very simple symptoms, so something like a clumsy or a weak hand, possibly a drop foot, but they may also present with difficulties in speaking, in swallowing, or even weakness of the trunk muscles and the breathing muscles. When we talk about degeneration of the motor system, what we're actually referring to, sorry, my slides are not perfectly advancing here. Sorry. When we talk about degeneration of the motor system, what we're actually referring to is a pathway that consists of two motor neurons, and those are known as the upper motor neuron and the lower motor neuron. The upper motor neuron resides in the cortex of the brain, and the lower motor neuron resides either in the brain stem or in the spinal cord. When we talk about typical ALS, that leads to degeneration of both the upper and the lower motor neuron. But we do know that there are disease variants that exist. So there are some forms of ALS that can affect only the upper motor neuron, and we call that primary lateral sclerosis, and also forms that affect the lower motor neuron. We call that progressive muscular atrophy. In addition, when it's the nerves to the speech and swallowing muscles that are affected, we refer to that as bulbar onset ALS. And the reason I think it's important to highlight and distinguish these subtypes is it really helps us with prognosis. We know that people with primary lateral sclerosis tend to have the best survival, whereas bulbar onset ALS tends to have the shortest survival. So helps us to sort of distinguish and guide patients in their journey. Before 1995, there was actually no effective treatment available for ALS. So in the early to mid 1990s, we were fortunate that there were two separate clinical trials published which showed a survival benefit of a few months, probably 4 or 5 months, with a drug known as Riluzole or Rilutec, which you see here. What Rilutec does is it blocks toxic effects of a neurotransmitter called glutamate, which is toxic to motor nerves or motor neurons. The good side is that the drug is easy to use, it's an oral medication, and it has relatively few side effects. The bad side is that it's not a perfect drug, it's not a cure, and there's more work to do because the survival benefit with ALS, with Riluzole, is only a mild one. So there was a lot of excitement in the ALS community after Riluzole was discovered because they thought that this was just the beginning of discovery of many new medications. The problem is, unfortunately, between 1995 and 2017, there were a number of failed clinical trials in ALS research. And people have talked about why that is, but I think there's really 4 main reasons why a number of compounds failed in clinical trials. Number 1, some of the drugs were unable to get access to the brain or spinal cord to actually have their effect. Number 2, some of them were embarked upon with a weak rationale or weak animal data before starting the study. Number 3, some of them had very good animal data, but a disease in an animal is not the same as a disease in a human, so they failed when tested in humans. And number 4, maybe we were catching patients too far in their disease when we were actually doing the clinical trial. Maybe we weren't catching people right at the onset of disease when we were giving them these medications. So I'm very thankful to say that recently there's been a bit of progress in the ALS research world, and that's as a result of a new medication that I'd like to tell you about, something called edaravone, which you may have read about in the newspaper in the last couple of weeks. Edaravone is a drug that was initially found to be effective in studies in Japan in patients who had a stroke, and it was effective when infused within the first 3 days of a stroke. What it does is scavenges free radicals and affects compounds called peroxyl radicals and peroxynitrate that does damage to cells and DNA. And it protects a number of different cell types. It protects neurons, which are nerve cells. It protects support cells, glial cells, and also protects vascular endothelial cells against the effects of oxidative stress. So obviously, when there was some thought that edaravone might be effective in ALS beyond its effect in stroke, the first thing that was done was to try it in a mouse model called a wobbler mice, which is a knockout mouse for ALS. And remarkably, it was actually shown both to slow the progression of disease, but also shown to slow the progression on pathology samples of the brain and spinal cord of these mice. So obviously that generated a lot of excitement. So the investigators moved on to a phase 2 study. And what that phase 2 study did was to examine the safety and effectiveness of edaravone in patients with ALS. And what they were able to show was that when given edaravone, the rate of progression of ALS actually slowed in the 6 months of treatment as compared to the 6 months before treatment. And they wanted to test whether edaravone was actually reducing oxidative stress. So they measured brain levels of a compound called 3-nitrotyrosine, which is a marker of oxidative stress, and it was almost undetectable at the 3-month time point. So obviously this phase 2 generated a lot of excitement, and so what needed to be done was to go to a phase 3 study to really test it in patients with ALS as well as healthy control, against the effects of a placebo drug. So the follow-up phase 3 study was performed, and this study was a little bit limited in that they limited it to a population of patients with ALS who were fairly early in their disease, who had breathing function intact, and people who weren't considered to be extremely slow progressors. And the reason they limited their inclusion criteria to that study is they didn't want to include patients who were already very advanced because they were worried they wouldn't be able to see an effect of the drug. When the data came out last year in late 2017, it was very exciting because the data actually showed a 33% slowing in the rate of decline of patients with ALS. So it really marked the first time in over 20 years that a new drug had been. In Canada, we're saying, well, our counterparts in the US have access to this medication. How come we don't have access, and how can we get access to this medication? Well, this led to some very interesting challenges for patients and for doctors because patients were either traveling to Japan to purchase the medication themselves or were organizing to have the medication shipped through a third party from Japan to Canada. And as physicians, we were saying, well, sure, of course you want to access this medication, but we want to make sure that the medication you're receiving from Japan is safe and that we can be sure it's administered in a safe fashion, in a monitored fashion in the hospital setting. And certainly there were some hiccups along the way, but I think we've come a long way in gaining access for patients to edaravone. So hot off the press, of course, is the news from a couple of weeks ago is that Health Canada granted expedited approval to edaravone. And we're all very, very hopeful that this medication will be more widely available to patients. At present, where things stand is it's received approval from Health Canada, but currently the provincial government and private insurers are negotiating with the manufacturer over the price. So I think there's still more news to come out in the near future as to what will be for patients. Okay, I think I would say that really one success doesn't tell us that that's time to end the game. It really just adds fuel and enthusiasm to the fire. We want more, and we want to do more for patients. So we're very excited to test other new drugs that are in the development pipeline. And I'm proud to say that in the very near future here in Ottawa, we'll be recruiting patients to 2 different ALS studies. One is a study of pimozide, which is a medication that showed a lot of promise in a zebrafish animal model of ALS. And the other is a phase 2b study of a compound called ACTH, or adrenocorticotropic hormone. There's a number of studies that are going on in other centers and things that are sort of on the horizon. Reldesemtiv is a drug that works on skeletal muscle on a compound called troponin, and that study is just wrapping up at a number of other centers, so we should get data on that in the very near future. And as well, there's a lot of promise for a drug called masitinib. Sorry, I forgot to advance my slide. There's a lot of promise for a drug called masitinib, which is an anti-cancer drug, a tyrosine kinase inhibitor. And that drug showed a lot of promise in early phase 1 studies, but we're still waiting to hear from the manufacturer as to when the phase 3 study will be launched. But keep in touch, should be coming soon. I have to admit, I think Dr. Rudnicki is going to touch on stem cells, so we get a lot of questions from patients about stem cells in ALS. There is currently a study of stem cells being injected into the spinal cord that's ongoing in ALS. It's a company called Brainstorm Therapeutics that's running its studies at a number of sites in the US. They elected not to have any Canadian sites for that study. I have to admit that my experience and my reading in the literature is there's not all that much excitement or promise on previous studies that have been done in stem cells. So while we're still holding out hope, I can't say it seems to be the panacea, at least in the ALS world. Okay, before wrapping up, I just want to say that research is important, research is critical if we're going to find a cure for neuromuscular diseases and ALS. But I think in the meantime, it's important that we continue to provide excellent and inspired clinical care to patients. And I think there's a number of things we do really well here in Ottawa, but one of the things we do really well is respiratory care for patients with ALS and other neuromuscular diseases. On the left, what you see is a gentleman who probably should have a mask for ventilation, but they've adapted his wheelchair and got him using a mouthpiece ventilator, and that allows him to take in breaths of pressurized air, but still be able to talk. So it's really a wonderful innovation that's been developed here locally. On the right, what you see is someone earlier in the course of the disease who's doing a technique called breath stacking or lung volume recruitment. And what that allows us to do is to recruit inactive portions of the lung to help with the strength of the cough and the strength of clearing secretions. So really, I think while we work on research and cures, it's important that we still focus on providing excellent clinical care to people affected with these diseases. And that's all I've got. So I thank you for your time.
So it's my pleasure to introduce our next speaker, Dr. Michael Rudnicki. So Dr. Rudnicki is a senior scientist and the director of the Regenerative Medicine Program and the Sprott Center for Stem Cell Research at the Ottawa Hospital Research Institute. He's a professor in the Department of Medicine in the University of Ottawa, and he's the scientific director of the Canadian Stem Cell Network and International Regulome Consortium. And to just give you insight into the impact that Dr. Rudnicki's research has had, Dr. Rudnicki has received the Order of Canada for the quality of work and the contributions that he's made in the areas of stem cell research and muscle development. So he really is a star internationally, and we're really lucky to have him here in Ottawa. So, Dr. Rudnicki.
Thank you, Robin. That Order of Canada thing, I'm convinced it was a clerical error of some sort. I don't understand it at all, but these things happen. You know how government works. So I've been a stem cell biologist my entire career. I began working with embryonal carcinoma cells, a stem cell of a tumor called a teratocarcinoma. I moved over to embryonic stem cells, working with those in mice to build engineered strains of mice. And now for the last number of years, I've been working on muscle stem cells. And there's really been incredible changes and acceleration occurring across the field. But let's move to the first slide. Oh, I do that. One thing that's, I think, Canadians should be aware of, that stem cell research here in Canada is at a level which makes us one of the major players in the world. Stem cells were discovered here in Canada by James Till and Ernst McCullough, working with very primitive equipment at the University of Toronto in the early 1960s. They went on to train postdocs and fellows, who then went on to train more postdocs and fellows. And today we punch well above our weight in stem cell research internationally. If hockey is Canada's sport, stem cell research is our science. I'm scientific director of the Canadian Stem Cell Network. Over the last 11, 14 years or so, the Stem Cell Network has forged a Canadian community, bringing together biologists, clinicians, bioengineers, ethicists to work together in multidisciplinary teams to accelerate the research. And indeed, the research has rapidly accelerated. On this slide, I'm sure you can read all the writing. But this itemizes some of the contributions that have occurred here in Canada. The discovery of neural stem cells, the discovery of muscle stem cells, the discovery of cancer stem cells. We punch well above our weight by metrics such as publications, patents, and so on. We are international players. Here in Ottawa, stem cell research and regenerative medicine research is also very well advanced. The Ottawa Hospital, the Ottawa Hospital Research Institute, is a center for stem cell research and also pushing that into the clinic. We are a major center for regenerative medicine clinical trials. And I don't think a lot of people in Ottawa understand or appreciate that. But like the Brain and Mind Institute and the Neuromuscular Institute, we are a really hotbed for science and for clinical translation. Next slide. So what's a stem cell? You're probably wondering that. What's a stem cell anyhow? So stem cells are very special stem cells in the body. In fact, the earliest embryo is formed by the most powerful stem cell called an embryonic stem cell. They were pretty controversial a few years ago, but now less so. As these stem cells go through and help build an embryo, they generate the cells that make up the building blocks of the body, so-called differentiated cells. And also stem cells change. They become more and more specialized so that by the time you're an adult, you have neural stem cells specialized in making the cells in the brain. You have muscle stem cells specialized in making cells in the muscle. Same in the gut, liver, etc., and the different organs. Stem cells have a couple of properties. One is when it divides, it self-renews, so it's maintained in the body. It's not lost. And then it makes capable of making rise of these, giving rise to these differentiated cells. That was the original simple criteria for describing them. Now we have a very precise genetic and molecular understanding of what makes stemness. What are the genes that give the stem cell its properties of being a stem cell? And this is a very active area of study. So stem cells start off very early as embryonic stem cells, and then as we go through making of an embryo, they like a tree, split off and specialize and make all of the different tissues that are found within the body. And we eventually, this is a mouse embryo, not a human embryo, a mouse embryo, and what's in blue is the muscle making cells that are marked. We made this picture in my lab many, many years ago. And you build the entire body, including all of the organs and so on. Of course, stem cells are maintained in all of our organs. Most of them, not all of them. Hearts, for example, don't have stem cells. And they're required to maintain the tissue, for us to grow and to repair damages, that is from trauma or disease. Of course, as we age, stem cells become less effective, sometimes in places that are in public, but that's okay. But we require stem cells to maintain the function of our bodies, and we can exploit and harness these stem cells to repair damage caused by disease. So my area of interest is muscle stem cells, and I'm talking about skeletal muscle, our voluntary muscle, not the heart. There are no stem cells in the heart, and not smooth muscle, which is doing a different job in the body. So it's our voluntary muscles. And stem cells can divide in different ways, and this is a particular issue that we've been drilling down into to really understand the molecular mechanisms that control this choice. So a stem cell can divide and divide symmetrically to give rise to two stem cells, increasing the number of stem cells, or when it can divide asymmetrically to give rise to one stem cell and another cell that's going to go on and eventually differentiate. This progenitor cell in green, also called a transient amplifying cell, can divide multiple times and amplify the numbers of cells. So a single division here gives rise to an army of cells that can repair the tissue. So small changes in the balance between symmetric and asymmetric division can have profound consequences for the ability to grow or to repair trauma. These cells can also be lost through direct differentiation. And you'll notice I'm showing a difference in the orientation of these cells relative to the muscle fiber that's running across here. And that's because they occur at different angles. The symmetric division always occurs parallel to the basal lamina where it's attached. And a asymmetric division always occurs at a 90-degree angle. So in order for these cells to make the decision of whether to do one cell division or another type of cell division, it needs to understand what is up, what is down, where's the ground, where's the sky. It has to have a polarity to understand where it is to make that decision. This balance between symmetric and asymmetric division, and this is a seesaw, shown here in this cartoon to give you an idea of how the balance can change in different conditions, really impacts the efficiency of the regeneration process by controlling the birth of these transient amplifying cells. If you have more symmetric division and less asymmetric division, the rate of generation of these cohorts of foot soldiers to repair the tissue is remarkably reduced. If you have more asymmetric division, you're making more progenitors, but you're self-renewing perhaps not enough, and your stem cell population can well decline, and that's what occurs in aging. We can alter the rate of that or that choice with molecules like Wnt7a, and which stimulates enhanced self-renewal by driving symmetric expansion, but not to the degree where we reduce too much the formation of progenitors, and you get everything working very much better. In aging, we lose symmetric division, and we lose the stem cell self-renewal, and so we have less of everything. If you go too far one way or too far the other way, you have a problem. In cancer, of course, you only have symmetric division, which is not good. And in Duchenne Muscular Dystrophy, which I'll tell you a little bit more about in a few minutes, or in the next slide, we have a loss of asymmetric division because of a new role for dystrophin. So what do we know about Duchenne Muscular Dystrophy? This is a genetic disease. The gene is on the female X chromosome, so that's why it's found in boys, because you only need one mutation. Boys are XY, sex chromosomes. You know, I'm getting into the science thing, sorry. But, you know, we're going to have a test at the end of this session. Multiple choice. It's just like university. If you pick B, you'll probably be okay. Just say B all the way down. So Duchenne Muscular Dystrophy is a horrible disease, horrible for the patient, horrible for the families. They're in wheelchairs, usually around age 8. Untreated, the boys will die as teenagers. With the best medical care, which is steroid treatment, they'll live into their 20s, some will live into their 30s, but it is a lethal genetic disease. The gene encodes a protein called dystrophin, a very large structural protein. This protein is part of a multi-protein complex that crosses the membrane called the dystrophin-associated glycoprotein complex with a dozen or so proteins. You can see it here in the bottom right. And essentially what this protein does is it joins the outside of the cell to the inside of the cell. It's like a rivet that goes from the inside, joining the inside of the cell to the outside, and the muscle fibers are covered with these rivets, giving it structural integrity. And so when you move, everything is protected and moves in register, and it stays intact. Without dystrophin, that entire complex is unstable, falls apart, and you've lost your rivets. And you have a loss of structural integrity, so movement causes membrane breaks that are long-lasting. They grow in size, and this leads to fiber death and fiber damage, and rounds of degeneration and regeneration, degeneration, regeneration, and then the tissue becomes filled with scar tissue and fatty infiltration. The stem cells that are present try to repair this damage, and in a phenomena that wasn't well understood but had been described previously, there was something that they called stem cell exhaustion occurring in these patients, and in also mouse models. But stem cell exhaustion doesn't mean depletion. In fact, they were increased in number. There's a 3 to 5-fold increase in the numbers of muscle stem cells at all stages of the disease, even very late in humans and in mice. And so this was a phenomenon that wasn't understood. We knew that, and we thought we knew, that dystrophin, this protein that makes these rivets in differentiated muscle fibers, wasn't present in myoblasts and probably not in stem cells. So it wasn't understood. Maybe it's overuse of the stem cell compartment that was causing this exhaustion. That was the thinking. Well, we made a couple of years ago a very important discovery that has utterly changed that understanding. And my apologies for this. From now we're getting into this really nitty-gritty of the science. But, you know, just pick B, you'll be fine. So this shows a normal cell dividing asymmetrically. So here's the basal lamina, which is its floor, essentially. And these cells have to develop a sense of their polarity and to know what is up and down. So at the North Pole here, dystrophin is recruited, and this complex attaches to the basal lamina, And we found a new role for dystrophin, which is in signaling. It recruits a molecule called PAR1B, which is a kinase. I'm getting too detailed, I'm sorry. Anyhow, it prevents the formation of what's called the PAR complex at this pole, and at the south pole, the PAR complex sets up. So you have different, at the north pole and the south pole, you have different complexes marking these two poles as being different. One is north and one is south. That allows the cell to know what's up, what's down. And what it then does is it recruits what are called centrosomes to those locations, and the chromosomes are then separated at an angle of 90 degrees to the basal lamina, and an asymmetric cell division can proceed and give rise to a progenitor cell. Now that progenitor cell can then go on to divide 8 or 12 times and make this cohort of foot soldiers to affect the repair. And you need to do an asymmetric division in order to give rise to these progenitors that make the myoblasts that then do the repair. What happens in Duchenne muscular dystrophy is dystrophin is absent. So this cell here, every direction becomes south. There is no North Pole. That PAR complex sets up all the way around the cell. So it's a cell lost in space. It doesn't know what's up and what's down. And it develops what we call multipolarity. It's really confused. It arrests and is eliminated and lost. And some cells still are able to achieve an asymmetric division, but it's reduced 5-fold. And because the rate of cell division is reduced by about half, it really means there's about a 10-fold reduction in the actual numbers of asymmetric divisions. This means that your stem cell compartment is giving rise to 10 times reduced rate of progenitors. So the flux from the stem cell to the progenitor compartment is turned down. So that the tap is turned down, it's going drip, 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 rather than being a full-on going through of water. So this has profound implications for the disease. Using genetic models, when we remove dystrophin just in the muscle fibers, it's a pretty mild muscular dystrophy. If we remove it in both the muscle fiber and the satellite cell, the muscle stem cell, you have a full-on muscular dystrophy. So what this means is that the really progressive nature of muscular dystrophy is due to two things. One is the damage in the muscle fiber caused by the loss of your rivets, and then this reduced ability to be able to repair the damage because of the impaired function in stem cells. So we've described a new way of thinking about Duchenne muscular dystrophy, and this suggests perhaps there's possible new strategies to address this therapeutically. So the next part of my talk, I'm going to tell you about unpublished studies, so lock the doors. And I'll have to make you all sign a confidentiality agreement. Oh, and this just explains the consequence of what happens with asymmetric divisions. You have a few children being born that can affect the repair of the tissue. Okay, so we were thinking, how can we address this? So we developed a platform to screen for drugs to identify new pathways that regulate this choice of asymmetric versus symmetric division. We identified a novel signaling pathway that had not been seen before in this context, and I won't go into detail about what that is, but we have now fully defined that pathway by genetic, biochemical, and molecular means, and we can believe we can modulate it. The goal being that if we restore asymmetric division by activating this new pathway, and restore asymmetric division in mouse models of Duchenne muscular dystrophy, restore the rate of progenitor formation, can we slow the disease progression? And in fact, that's exactly what we found. In a very phenomenal way, by turning that, or restoring the balance of that seesaw, we can generate sufficient numbers of progenitors to repair that damage. And these muscles display a very healthy, relatively speaking, phenotype. They're capable of generating force by increase in force generation by about 30%. This is really a really remarkable restoration of capabilities simply on improving the regeneration capacity of the muscle. We haven't introduced dystrophin into muscle fibers. It's still a genetic disease. But by getting regeneration back to normal, we're really ameliorating the progression of the disease. This EGF Aurora kinase A PAR-D3 pathway enforces an alternative path of polarity that's independent of dystrophin, and we can restore the asymmetric divisions in these dystrophic mice. This is a very exciting development. Right now, we're searching for small molecule drugs that do the same thing, actually we have some very interesting leads, and we're very excited about the future where we can use these small molecules, a pill or perhaps an injectable, to enhance the regenerative capacity of the mice and eventually in humans. And where we see this going is that, as you may know, gene therapy is looking very promising in diseases like Duchenne Muscular Dystrophy. The vectors that deliver the gene, however, only infect the differentiated muscle fibers, not the stem cell. So these little children have to grow up 20-fold increase or more in mass. And we think an intervention that targets the stem cell compartment together with gene therapeutic interventions will have possibly curative changes for the lives of these patients. And this just shows you, illustrates you with a lack of asymmetric divisions, you don't have enough foot soldiers available to plug all the damage, and you have fiber death. And when we restore the balance, we amplify the formation of progenitors to the extent that we can keep up with the damage as it occurs, leading to fiber survival. And that's what our preclinical data is strongly arguing what's happening. Thank you very much.
Michael's a little taller than me. We just wanted to thank you for coming tonight. That was Dr. Rudnicki was our last speaker. There we go. Perfect. Thank you. There we go. So we just wanted to give you an oversense about how, from an innovative clinical care perspective and the groundbreaking research, that we want to offer excellence in clinical care and research. And sometimes people will ask, well, what can we do? What can we do? This is really exciting. What can we do to help? So from the University of Ottawa Brain and Mind Research Institute, they have an ambassador program that's very exciting about supporting neuroscience research in Ottawa. As part of the clinical registries, to be involved with the Canadian Neuromuscular Disease Research, CanNMD, and we're also starting an Ottawa-based registry. When your clinician might say, do you mind if we have a clinical sample? This is all through the Research Ethics Board. You know, where we want to support Dr. Rudnicki's laboratory work or Dr. Parks's work to move the therapies forward. To support the trainees, so we've got the basic science graduate students and the medical students and fellows. We want to encourage the next generation to be involved in neuromuscular disease. The worst thing that could happen to advance science is that we don't have enough people to keep up the good work. And the last thing is to support research in the laboratories. So the clinical care is supported, but the innovative neuromuscular research is not. So from the foundation at the university, the foundation at the hospital, and your favorite scientist lab will always appreciate your support. So thank you very much for your time tonight. And we would be happy for all to come up and take your questions. Thank you very much. And if anybody has any questions, if they could come please to the microphone, that would be great. And sometimes in a group it's hard to ask questions, so we will all be available for a little while afterwards if people want to come up and approach us individually as well.
When's the exam?
Yeah. I know, I've heard I have to pick B.
Hi, I just want to know if glutamate levels at the present time can be actually measured.
So I don't know.
Oh.
You know, like you were talking about the glutamate in terms of the, was it the Rizzo?
Yeah, so serum glutamate is not routinely used in clinical practice, but the idea of glutamate comes from the first gene called SOD, which was discovered in ALS, but it's not something that has any meaningful clinical value, a serum glutamate level.
But yet the ridazole decreases it though.
Yeah, but remember that's acting at the level of the brain.
Okay, so at the present time, we don't
Yeah,
even measure
we
that,
don't
right?
use it, yeah.
Okay, thank you.
I was just wondering, the stem cell research that's being done, Dr. Rudnicki, does it have potential applicability to other forms of neuromuscular disease other than Duchenne?
Yeah, absolutely, yes. Without question. And, you know, I have a particular focus on Duchenne muscular dystrophy because we have good animal models and a good understanding of the molecular basis of the disease, but we're really interested in extending what we're doing to other genetic muscle diseases, also other tissues. And we've been working with neuroscientist colleagues at the university and in the institute and extending our findings to the central nervous system and to the retina. So we're very excited about the concept of modulating asymmetric division in a variety of settings. And we can push it one way or the other. And we believe it points to a potential way forward to even address some very complicated things like cancer cachexia, COPD, loss of muscle mass, sarcopenia in the elderly, etc. So we're interested in expanding and looking at multiple indications.
Anyone else?
Heck, I'll ask another one. You know the neuron, is it the neuron that's dealing with the stem cells? They're actually thinking about removing stem cells from the patient and then making them neurogenic and then reintroducing them back into the patient on an individual basis. Basically to make them neurogenic, in other words, clean up the cesspool that the neurons are actually sitting in terms of the glia cells or the mummy cells to look after them. Those poor little babies need care. What do you think about that?
So I imagine you're referring to the trials in ALS.
Yes, I am.
Yeah. So I think...
I want to get there as soon as possible.
I hear you. Me too. So I think the challenge is this. Ideally, what you want to do with a stem cell in ALS is get the stem cell to ingrain itself in the spinal cord where the normal motor neurons live, and then grow its tentacles out to the periphery to allow the hands and feet to work properly. That is a much bigger challenge than it seems. And the current trials that are going on with stem cells in ALS are actually not trying to achieve that aim. So what they are doing is using stem cells as essentially a cleanup job in the spinal cord, so to clean up neuroinflammation and free radicals in the spinal cord. And that's why I sort of tempered some of the enthusiasm around stem cells for ALS at the present time, because I think it's not actually addressing what stem cells need to do, which is replace motor neurons that are being affected by the disease.
But even though the motor neurons, if you clean up the cesspool, are we not going to increase the longevity of the patient?
Well, I don't think there's data to actually support that yet, but the brainstorm data should come out soon. They're recruiting at US sites now.
Do you know why they didn't do it in Canada? How
Why
come they
they-
didn't actually have a phase 3 in Canada?
Yeah, so the phase 3 is what's ongoing now, but I think that just has to do with logistics. There have been a number of people that have looked at going to sites in the US, in Boston and elsewhere, and the company has actually been open to Canadian patients participating, so they haven't ruled that out. But I think the reason they set up in the US is probably just a feasibility one. I don't know. I know there's a Canadian, is one of their chief medical officers, so I think they're open to having Canadian patients participate.
Anybody else for a question?
Thank you.
Okay, there's lots of patients here tonight. We all have data. Nobody's collecting our data. What sort of data science support do you have so far? Are you doing pattern recognition? Are you doing AI? What's happening? we want to give you our data, we want to help. What's
Well,
happening?
So I think beforehand, before the Clinical Research Center opened, we just didn't have the capacity. So it's not that the clinicians don't want to take the data, but from a patient visit, people will be there for much longer. So now that we've got the Clinical Research Center, we are talking to the hospital administration about having a nurse to help us collect data, to have more people infrastructure. So we've got it started, we've got a big space, but we have to fill it.
Okay, but right now there's things like my charts, okay? We all go to the Ottawa hospitals and there's my charts. Why aren't you mining that data?
We are actually, so we are mining the data, but and as Epic is coming in, so the my chart is about a 5% about what we're able to mine as far as data. When Epic opens next year, so this is a huge investment, that's $160 million of Epic, and we use Epic at BHAW, and most of the hospitals across Canada and the US that are upgrading their technology, there's two big companies and Epic's one of the big ones. So Epic will significantly increase our ability to collect data, with patient consent and research ethics board support, of course. But that will be one way to mine data. And actually, we were talking about that today, that with Epic, so let's say with certain questionnaires for studies, you can actually log into your chart before your visit, do the questionnaire, and then when you're seeing your neurologist the next day or the next week, you can actually discuss some of the data and some of the answers off the questionnaire. So that will significantly increase with Epic, but obviously not one group has $160 million to invest in this new program. So as a group as a whole, we are.
Okay, thank you.
Thank you.
Are there any other questions?
So I think one more.
So in the US, some researchers have decided to use platforms like, sorry, I'm nervous. Platforms like Patients Like Me for various diseases where people can't always come in.
Yeah.
Do you plan to look into that sort of?
Like a telehealth sort of?
Yeah.
I have actually done telehealth for some patients, but it's tricky, and there are very strict criteria, because obviously they don't want physicians to be assessing patients from their pajamas at home, there's a lot of strict criteria. So I'm being facetious.
Yeah, but for research, not for care.
I see what you mean. Yeah, it's funny, we hadn't had a lot of opportunity to do that, but with now that there's new infrastructure, and actually all of the clinical research rooms now have webcams, so we can have interactions between different physicians, but that's an interesting perspective of also doing that as a research tool.
Yeah, because Richard Bedlack is doing that out at Duke right now for Patients Like Me trial. So it's interesting, kind of a privacy issue there, but I mean...
there's secure connections, and there's certainly ways of
well,
doing
no,
that.
Patients Like Me is private,
Yeah.
so it's a totally different privacy level. So I used to work for the privacy commissioner. So, yeah, so in the US, different laws, but it's interesting to see how research is accommodating people and not vice versa. So maybe your new center, you can look at maybe being more accommodating.
It's a great suggesting. Thank you.
I can speak to that.
Sure.
There is an Ottawa startup company that allows a secure connection, that's whatever your ISO thing is, that Canadian hospitals are using and trialing right now, that allows the doctors to speak to the patient and monitor the patient on a number of different platforms, like everything from EEGs to blood sugar to whatever you need. And they are being trialed, and it's an Ottawa-based company, and that is being used now. So the capability is out there. It's right here in Ottawa. So, we want to help. We want you to use these things.
And that's a great suggestion. And for certain clinical visits, that's great. A lot of the time we need physical assessments to assess or biomarkers with fluid. So it would certainly be a great idea for many patient visits. Sometimes we really actually need to test the strength from to make sure that there has been progression, or to look for other things you wouldn't necessarily get through. So, that is definitely an excellent suggestion, and one that we can certainly incorporate for certain research visits and certain clinic visits. And I think, one question.
Thank you. So when it comes to getting data for the center at the Civic Hospital, when the patient goes in for an assessment, for example, does the neurologist then, or the doctor at that point, do they suggest, hey, let's take a sample, or is it up to the patient, or does it the patient, you guys can be calling them in saying, hey, do you want to come in for a sample, or is it only during appointments?
So I think it depends. Part of it, we actually have written a large research ethics board proposal to do just that, so that when patients come in and are giving their clinical samples, that we would, with proper REB consent, be able to take any tissue that was being taken as part of the clinical visit and to be used for research. So, there's some patients that will come in and give special research visits, and for a lot of clinical trials are like that. But, we need to incorporate this as part of the clinical care, or it's going to just move at a snail's pace. And so we've actually developed a large REB for all of our patients with rare neuromuscular disease, so as an example, so let's say we have a patient with a rare disease that are on a certain medication. If we can't go back and look at their EKGs or their respiratory function or certain blood markers, we won't know if this medication, might be making something overall better or something overall worse. And so it's critical to look at the patient as a whole for clinical data, but as well as their biomarkers and their samples. So, and this is a problem across Canada, to the point that our REB has been submitted to Clinical Trials Ontario, so that all of our Ontario colleagues have used it. And after that's gone through there, we've offered to make it available to everyone in Canada, so that the work that we have done will help all Canadians with rare neuromuscular disease, and it will help the clinicians and the scientists that don't have as many resources as we do in Ottawa move things forward locally for themselves. And also this REB will help patients. So let's say Dr. Rudnicki has a colleague in Vancouver. If they've been consented on the same REB, they can actually share patient samples as it's gone through REB. So then all of a sudden you take the power of one city and make it across the country. And that will, supports the open science philosophy that all of these samples and all the patient, anonymized patient data, of course, should be able to move the research forward.
Thank you.
So I think if there, one more question?
In terms of the clinical trials, I'm getting the impression that the older that a patient gets in terms of the advancement of the disease, the less likelihood that they'll be included in the trial. Now, is it just based on the fact that they've had it for example, it seems to be the average is 2 to 2.5 years kind of thing before they're allowed in? Number one, I think it's a money issue, right? Because no pharmaceutical wants to invest if it's not successful. But is it just that, if they still meet the breathing aspect, I think it's usually 80% or whatever it is, would they still, despite the fact that they're over 2.5 years, be included in the clinical trial?
So lots of good questions. I think in general those numbers are arbitrary, but they're set by the sponsor of the trial, and in general you're right, it's a 2-year cutoff. And I think that comes from the fact that some studies have failed and recruited all comers. And then in retrospect, they said, had we included people earlier in the disease, we may have seen a result. So they did a subgroup analysis later, and they said, we should have designed the trial differently. So I think as a general rule, most studies that are coming out now are limiting it to 2 years from the time of diagnosis. And that's done in an arbitrary fashion, but it's done to exclude people who are too advanced as to benefit from the particular medication. So in general, you have to meet all the exclusion criteria. So if you're beyond that 2 years, they won't, from the time of diagnosis, even if your breathing is normal, they won't include you.
Well, that's not good.
Yeah, that's not always up to the center. In general, that's up to the sponsor of the trial. Yeah.
And the only other comment I was going to make is I have a colleague who was diagnosed 2 years ago with MS, and it was very progressive, and she got to the point where she couldn't breathe and all that kind of stuff and swallow. And literally she had 3 stem cell treatments, and today She is as vibrant as you would see. She's back to teaching, looking after kids, and it was 3 stem cell. So I mean, I'm all for stem cells, and I realize that the problem with stem cells, but it's just there's one success. And it could have been her biochemistry or whatever, but it did work with her.
So I guess that's a credit to some of the work locally here in Ottawa, and Dr. Atkins and Dr. Mark Freeman have got a lot of wonderful press and wonderful publications, and I think it's to their credit, the work they've done in MS patients with stem cell therapy.
Yeah, so those trials, they've done they're very, very effective, and it essentially has become the standard of care in the Ottawa area, the Casement area, for severe progressive MS to have a bone marrow transplant. So this is not a neural stem cell transplant. This is a rebooting of the immune system so that the autoimmune disease is no longer present. And the body's own regenerative abilities restore the patient to some degree. And it's really a phenomenal success story.
I was going to say, are there any more questions? But every time I say that,
I got no more.
Oh, yeah. In that case. So we will remain available if anybody would like to come up and ask any questions, but we really thank you for your time and coming out tonight and finding this room as well, because I know that could be a challenge. But thank you very much for your time, and thank you very much to our speakers that spent their time.